the Parkinson's of Alabama. And it's my pleasure to introduce Dr. Ramon Gill. He is from the Parkinson's Disease Treatment Center of Southwest Florida. And Dr. Gill has been practicing for several decades and has been associated with the Parkinson's disease and really all movement disorders. But him and his practice are the non-academic site in Southwest Florida, participating in more than 130 clinical trials um, in the field of Parkinson's disease and other movement disorders as well. He's connected to the Parkinson's community for again decades and decades, and it's an honor to have you on here, Dr. Gill. And he's going to run through a little bit about ONAPGO, which was launched in 2025 in April, May timeframe. So we're really excited to get it out there. And as we get going here, please raise your hand on the Zoom call. You can raise your hand anytime, and we'll take questions, or you can chat. But at the end of the call, we'll take questions as well. So if you have questions during the presentation, just raise your hand, and or if you want to just chat it, we will get to it. And that's about all I got. So, Dr. Gill, thank you for joining, and look forward to hearing from you.
Thank you. Thank you, Shane, and thank you, Supernus, for making this presentation possible. A couple of notes. Just like Shane said, I've been practicing neurology, but not really for decades and decades like he made it sound. I started my practice only in 1989, and I can't believe that this coming July, my son is going to be 40-year old. So I guess my days are passing by and kind of growing with more experience. Anyways, this is a very informative presentation, and I hope that you enjoy it. I want to make it very interactive, and I want to tell you that this is a promotional talk, and the company Supernus is reimbursing me for my time and for my presentation and expertise in this field. Uh, I I've been working with apomorphine, which is obviously the drug here, for many years. Actually, I go back to the year 2000 and 2001 to do some of the pivotal trials for this medication in this country and pharmacokinetic studies, which in those days were leading to the approval of Apoquine, which is this medication but injectable for intermittent use to treat the wearing off episodes. For many years, we've been trying to do what has been done in Europe for decades, for sure, which is the use of apomorphine, not just intermittent, but in a continuous infusion, as we are able to do now with ONAPGO. So this is an old medication in a novel presentation for our country. And again, the experience with this medication goes for easily 25, if not longer, number of years in Europe. Um, we are going to review today a levodopa as the main drug for Parkinson's disease and why levodopa and the off time or the off periods are kind of interrelated. And we are going to also talk about the impact of off periods in your lifestyle and in your social activities. We will also talk about how ONAPGO, which is the brand name of the apomorphine infusion, provide you with more good on time. Now, as you all know, levodopa is the most effective symptomatic drug for the treatment of Parkinson's disease, particularly the motor symptoms of Parkinson's. However, the journey of levodopa to go from the mouth to the stomach to the intestines, to the bloodstream, to the brain, to cross the blood-brain barrier, to get to the neurons that will release the product of levodopa once it's in the brain, which is dopamine, to the next cell or neuron, is a long and difficult journey. And there are many barriers for levodopa to make it. And that is one of the reasons why eventually many patients have increasing problems with the quality of the response. And also, as the disease progresses, the need for more dopamine uh, involve increasing the dose of the levodopa. The levodopa also lasts less or a shorter period of effective treatment, and you end up combining levodopa with other drugs to make it last longer. And despite all those efforts, you're going to find out that you have more off time and less quality or lower quality on time. Okay, so these are some of the limitations that we see over time with levodopa as the disease progresses. Um, all of you have probably heard that when patients are initially treated, they use levodopa, the IR 25 over 100 3 times a day. That's kind of the standard dose. But you will see that within the following couple of years, they have to increase the medication to 4 and to 5 times a day and so on. And you end up living a life almost watching your clock to take your next medication. And that creates a lot of problems with your activities of daily living, planning social activities. You have to coordinate when are you going to go to the bank to make sure that you are on when you are there or any party and so forth. So there is always a need for us to make the response of levodopa more reliable. Now, I was telling you earlier that the journey is pretty difficult and long, and here is the first, quite often underestimated problem that patients with Parkinson's disease have. The stomach in patients with Parkinson's disease is affected in such way that the empty mechanisms are slower, and then things stay longer in the stomach. And as you can see here, that is a picture of the stomach with the carbidopa levodopa tablet sitting in the stomach. And that patient obviously did not get a response to that dose. Why? Because the medication simply was not moved to the small intestine where it is absorbed, or it took a lot longer. And by then, the patient was really off or experiencing what is called delay on and sometimes skip dose phenomenon. Those are patients that will tell you, I take the medication and for whatever reasons, it didn't do anything and I was off for 3, 4 hours. Um, then, when the patients take the medication and finally empty exit the stomach, you go to the small intestine and they have to fight with different amino acids and different components and protein that is being also attempt to be absorbed. And when protein and levodopa are together trying to be absorbed, protein always win, and then you have less absorption of levodopa than what you like. That is why it's not that patients must take the levodopa on an empty stomach, is that they need to watch the amount of protein that they ingest around the time of the medication. So if you are planning to have your dinner tonight, 12 ounce New York Strip, well, you need to make sure that your levodopa is taken 1 hour apart or 1.5 hour apart from that meal. And really, it's not all medications. It's not that you have to have an empty stomach. Then, when the medication is absorbed in the bloodstream, still is competing with different chemical compounds uh, to make it to the brain. And when it gets to the brain, it has to cross the blood-brain barrier. The blood-brain barrier is a sort of a protection that got designed for the brain to make sure that whatever gets to the brain has been selected. So there are many different toxins and many different things and drugs and so on that do not penetrate the blood-brain barrier as a protective mechanism for the brain. Well, a dopamine, if you give it uh, intravenously, it really does not cross the blood-brain barrier. Levodopa does. And when levodopa crosses the blood-brain barrier, it becomes like a Trojan horse because inside the brain, it is transformed into dopamine. And then that dopamine goes to what we call the presynaptic neuron, and from the presynaptic neuron is released to the postsynaptic neuron, where there is what we call the dopamine receptor, and then it works. So again, it's not that easy. Okay, so what happens as the disease move along? The first thing that you know that you need to keep in mind is that motor fluctuations or the off episodes occur relatively early into the course of the disease. As a matter of fact, the numbers that you see here are rather conservative. There are studies showing that half of the patients treated with levodopa will develop motor fluctuations within 2 years. And a third of the patients will experience dyskinesias within the first 2 years. Those are some of the studies that have been published over the years. Now, in more recent studies, and due to many different factors, yes, motor fluctuations may be seen less often within the first 2 years than before, but I assure you that by 4 or 5 years, half of the patients will be fluctuating. Now, they talk about 90% of the patients by 10 years. I've been practicing neurology since 1989, and I am telling you, I have never seen a patient with 10 years with Parkinson's disease that is not wearing off. I just haven't seen that. So that's a very conservative number. Part of the problem also with the off periods is that they could be predictable in the sense that, well, you know that your next dose of levodopa is coming at 12 noon, so by 11:30 you are kind of expecting to feel a little bit worse. But there are other patients that experience unpredictable off. And that has to do again with absorption problems for the medication. And those could be quite distressing and disabling because the patient is engaged in activities depending on the medication, and all of a sudden, worse off in the middle of a dose. Now, here is a video showing you a person in the off state, and see how slow he got up from the chair. See the steps that are shorter than normal. He is moving the arms fairly good. I almost feel that he is pushing his arms intentionally to walk a little better. But that is in the off state. And these conditions, this slowness, those baby steps, which are really what we call freezing of gait, or one way of experiencing freezing of gait, are quite disabling, or could be quite disabling and impairing your daily activities. And what are the symptoms of the off state? Well, reemergence of your symptoms of Parkinson's that could be motor and non-motor. So yes, shuffling, slowness, stiffness, tremor, but also keep in mind that non-motor symptoms of Parkinson's are quite often present, including anxiety, which could be quite disruptive. So look at the difference now, how brisk, how loose this patient is. He moves normally. He has a much better stride. His steps are longer. He has much better mobility. That is a good quality on that the patient is now experiencing. And this is a representation of how this person goes throughout the day. And this really parallels what many of you are experiencing right now in this kind of a yo yo all day long. You wake up and you are off, you take your medication, an hour later you are going on, then by 2 hours later you start losing ground, and then 3.5 hours, 4 hours later, you are off, and the whole thing repeats over and over uh, every day. Granted, there are now, and for a number of years, longer acting forms of levodopa, but they are not perfect, and patients may still experience significant off time. Because again, it's not just the formulation of the disease, excuse me, it's not just the formulation of the medication that is leading this, it's also your gastrointestinal tract, your stomach, your intestines, constipation, protein, etc., that disrupt the response to the levodopa. Um, the Michael J. Fox Foundation surveyed more than 3,000 patients, and in 50% of the cases, they report that they avoid or stop activities as a result of the off time. And 65% of the patients in that study experience off periods for more than 2 hours a day. Actually, I will tell you, when you look at patients that have 4, 5 years into the disease, you will easily quantify 3 hours of off time if you keep in mind that the off time starts when your response starts declining. So you take the medication, you are at best, and then 3.5 hours later, you start losing ground. Well, that is wearing off. And then the time of the medication comes, and then it takes again half an hour, 45 minutes, for some people, sometimes even 1 hour, to go back to be at best. So that period is the wearing off or the off time. Um, and these are things that you have to keep in mind, because the idea of treating you guys with medications for Parkinson's disease, again, levodopa being the number one, is to keep you on all day long. You don't want to be in these up and downs that you saw in the previous slides. And here is now a patient that is on ABGO. Let's listen to her as she explained to you how, the impact or her experience as she has off time. Okay, Susie mentioned there a medication called ropinirole. And I just want to make a point here. I mentioned earlier that for many patients, we combine different drugs and we add medications to prolong the duration of the levodopa. And there is a whole family of drugs called dopamine agonists. And dopamine agonists are very effective. They work like if there will be dopamine in the brain. They last longer than levodopa. There are even formulations of dopamine agonists that could be used effectively once a day. The problem is that these drugs are not well tolerated by senior patients, and even in young adults with Parkinson's, one has to monitor uh, many things because of the potential side effect affecting behavior, cognition, weight gain, compulsive behavior, impulsivity, uh, hallucinations, delusions. So these are drugs that are effective, but not particularly able to be used in the older population and have to be used carefully in younger patients. Um, the other thing is, guys, you need to uh, keep in mind that there are ways for your treatment to be effective, providing you best quality on most, if not all day long. Do not be satisfied with mediocrity. Don't just accept, well, I'm being treated and I have 3, 4 hours of off time. That is not really, or that shouldn't be accepted. Okay, now, even when you adjust medications, good on times have issues and problems that are sometimes more difficult to address. For example, as you try to combine medications and as you try to push what we call the dopaminergic therapy, you will have other limitations that could come, like dyskinesias, that we could talk about that later on. But just keeping in mind all these uh, regulations or limitations about food, how many times a day, how many doses a day, it is really a major inconvenience for all of you. And still, with all these things, you have off periods. So that's where we have to talk about a new therapy that is subcutaneous infusion, in this case, ONAPGO, which is apomorphine. Well, the number one major difference is that this treatment is continuous. This treatment goes on all day long. You get your medication subcutaneously. It's like an insulin pump, okay? And because it is in the abdominal wall, in the subcutaneous tissue that you are delivering the medication, it has nothing to do with your stomach or your constipation or your meals. And you have a much better a response because the medication apomorphine goes straight to the brain. And that's another critical point here to differentiate apomorphine from levodopa. The treatment with apomorphine is continuous, is predictable, and is consistent. There are some warnings about this medication, like it could cause sedation, sleepiness, it could cause low blood pressure, which in general, all the dopaminergic drugs have that potential side effect. It could cause confusion, hallucinations. And again, all these are prescription drugs. They are medications that it's not like all one size fit all. We have to individualize the treatment and select the right patient for this type of treatment. Okay, and some warning or some advices: avoid the use of alcohol because the major problem with alcohol is that alcohol is a vasodilator, and then it could drop your blood pressure, which may already be low because of Parkinson's, more so on medications like Onapgo or Levodopa as well. Um, okay, let's go back and see how Onapgo works. Onapgo or apomorphine is actually a dopamine agonist. It's a dopamine agonist, like I was just mentioning before, that has some disadvantages, this family of drugs. Okay. Now, interestingly, when apomorphine is used subcutaneously, the incidence of these behavioral problems, confusion, hallucinations is a lot less than when we were using it intermittently, and is certainly less than when we use dopamine agonists by mouth. So, contrary to what one may expect, the use of apomorphine infusion is much safer than oral dopamine agonists for patients of any age, including obviously older patients. The Onapgo, the apomorphine being infused uh, in the abdominal wall, goes straight to the bloodstream, is not impacted by your diet or protein and so forth, and you don't have to have any issue concerning a diet, time of your meals, constipation, etc. Now, the other interesting thing is that apomorphine crosses the blood-brain barrier. And not only that, when it goes to the brain, it goes straight to the postsynaptic neuron, it goes straight to the neuron where the dopamine receptor is, and it stimulates the dopamine receptor as if it would be dopamine itself. So when you compare how easy is for apomorphine to stimulate the dopamine receptor, that in itself is a huge advantage over levodopa that has so many stop signs or barriers to get to be effective. Now, when you measure the clinical response of levodopa versus apomorphine, you will see that the response to levodopa is a few points better than apomorphine. Now, when we are using apomorphine infusion, the idea is not to substitute your levodopa. The idea is to be able to reduce the dose of your levodopa, to reduce some of the complications and problems that you may be experiencing by then, like the dyskinesias, but also to provide you a steady response all day long rather than the ups and downs. And in that regard, apomorphine is more consistent and more effective than levodopa in the sense of how it stimulates the brain without needing all these extra help, including the transfer from the presynaptic to the postsynaptic neuron. Keep in mind that in advanced stages of the disease, the degeneration of the brain that is taking place as a result of Parkinson's disease leads to defective mechanisms in these neurons to release the dopamine. So it's not that levodopa stopped working, is that the response of levodopa 15, 20 years down the road is less reliable and less robust when compared with a in early or middle of the road disease. Now, if you have a person on Onapgo, this is how the day looks. They wake up, they may be off, they get the infusion going, and here you go in a continuous on a state of good quality. By the way, you have the advantage that in the pump, if you feel that the quality of your own time is coming down, you could give yourself an extra dose and then you improve the quality of your own time. So you should never have any major problem in that regards. And this is very simple to assemble or prepare and infuse. You will be trained by nurses from Supernus, and we won't initiate this treatment until we are all assured that you and your care partner are familiarized with the pump, that know how to use it, that know the basic principles of hygiene, which is very important. Very important. The most significant concern that most of us have with this treatment is the development of skin reactions, including infections, that needs to be minimized with very good hygiene. Okay. Um, the pump is small and is like the size of a cell phone. And here is Susie showing us how she's assembling the kit. Okay, so I'm going to show you now a few slides about a major study that was conducted to demonstrate the safety and the efficacy of ONAPGO. And this was obviously a study in patients with Parkinson's disease. The duration of the study was for 12 weeks. Those patients had or were experiencing off time, and they were all quantified in terms of how many hours they were off, how many hours they were uh, on with good quality on or good on time. And they had different assessments, including an assessment in terms of how patients perceive the well being or their general health. And we also monitor in this study the reduction in the concomitant drugs that patients were taking for Parkinson's. Okay, and the conclusions were, as I'm going to show you in a moment, that the patients consistently found reduction in the off time, increase in the good on time, improvement in the general health feeling, and lower number of medications a day. Okay, so at the end of 12 weeks, patients were able to document that they had a reduction of 2.6 hours of off time versus zero point 0.9 hours with the placebo infusion. So clearly a much more effective treatment. By the way, the patients that were on the placebo infusion were taking quote unquote optimal doses of oral carbidopa levodopa. In addition to the reduction in the off time, patients had 2.8 hours increase or more good on time. So that's also very important. And those patients, when compared with the placebo, did also very well because the placebo group only improved 1.1 hour versus 2.8 for the active drug. At the end of 12 weeks, 80% or near 80% of the patients were reporting a feeling of overall improving in the general health, which is really a way to express or a way to demonstrate how much better your overall functioning is because you are stronger, better mobility, more independent. Your symptoms of Parkinson's are much better controlled all day long than otherwise. And these were other observations. By week 4, 33% of the people in the ONAPGO group were able to stop taking one or more of the medications for Parkinson's versus 6% in the placebo group. And 15% reduction was found in the dose of levodopa versus 5% in the placebo. Now, this is another type of graphic to show you the results of the study. At the beginning, the group had as an average 8.6 hours of good on time, which went up to 11.4. And the off time, that at the beginning was 6.7 hours of off time, went down to 4.1 hours of off time. Again, some of the side effects and warnings. Nausea and vomiting are the most common side effect of this medication. But again, apomorphine infusion is much better tolerated than the one that we were used to, which is the intermittent use of the so-called apoquine. They mentioned here the side reactions, and as I say, you could have some redness and irritation and little swelling from the reaction of to the medication itself, but also cellulitis or infection that may require antibiotics. And the way to prevent that is good technique to clean the area and use the cannula properly. And here is another video of Susie reporting on her own experience with the medication.
Really glad I tried it. It's worked very well for me.
Okay, so again, this is the summary of the study. The patients study in this clinical trial found reduction in the off time, increased amount of good on time, improved general health, and reduction in the number of medications that they were taking by mouth for the treatment of Parkinson's disease. Reduction in the off time, 2.6 hours, increase in the on time, 2.8 hours, and 80% of the patients reported feeling better in terms of the general health. As I mentioned before, Supernus have an excellent program of nurses that they will train you, they will support you at the beginning in terms of what needs to be done to use the medication. You always have a 1-800 number to call and ask questions or troubleshoot your pump if there is any issue. And there is also a very effective program for financial assistance and specialty pharmacies. I must confess that when we prescribe ONAPGO, it's really very simple for us because, in a way, they take care of everything else behind the scenes. Okay. Getting started with ONAPGO, this could be done at home. There are doctors like me that are very jealous of my patients, and I don't like anybody to take care of the patients at home, and I don't see them. So my patients are always started in my office, but this could be done also at home, and they have the way to coordinate everything with your doctor and so forth. And I don't know if you guys have any questions or if there is anything. These are just statements again that we have made before, just in summary ONAPGO provides a continuous treatment, predictable, and a consistent response to minimize your symptoms of Parkinson's disease. And I'm open to questions. Shane, any questions?
Yeah. Thank you, Doc. I appreciate it. Really well done. Hey, I was gonna talk about the pill burden, or once you get optimized on a NAPCO, and I think you touched on this obviously, but you this is an adjunct therapy, correct?
Yeah.
So you would be able to take this, but as when you're at your expectation, I think it would be folks will start to come off of medication because it is adjunct.
There will be a reduction in the number of pills and doses and so on, but kind of similar to DBS or deep brain stimulation. The goal is not that I am going to be able to stop all my medications. The goal is going to be better response, sustained response, continuous efficacy, less medication, less side effects.
Yep, that makes sense. Great. And then there was a question here. Are there any restrictions or activities I should avoid when using the device?
Well, don't jump to a pool with the pump on. That's one. But in general, no, there are no real restrictions physically. And if you do decide to get in a pool, you need to just keep in mind that when you disconnect the pump and you put it back, you need to give, chances are, an extra dose, and you should not stay off the pump for, let's say, a lengthy period of time. I mean, I wouldn't advise to be off the pump for 1 hour. You know what I mean?
Yes, absolutely. That makes sense. Another thing I had was the good on time. When you say good on time, you explained it well, and the slides did, but could you just explain what good on time means again? And
all right. Patients with motor complications of Parkinson's go through off, on time, good on time, or best on time, and then on time with dyskinesias. And the dyskinesias could be troublesome or non-troublesome. And what we want is to see patients enjoying more good quality on time. Eh, I don't know, you probably have not heard this before, but I created a concept of what I call the dimmer switch. Because in Parkinson's, this on and off is not like a regular switch that you go on, off, on, off. No, in Parkinson's, you really have a dimmer switch. And your off time may not be the worst. The worst off time is 0 in the dimmer switch. And then you go 0, 1, and 2, and those are off time because the light is not that good when you are 0, 1, or 2. And then 3 is a transition to on. Is when patients tell you, oh, I feel that my medication are starting to work, but that's far from being a good on. And then you go 4, 5, 6, and 7. And those are better quality of the on state. 7 being the best on that you patient are able to enjoy without dyskinesias. Okay, the minute you have mild dyskinesias, yes, you are on, but that's an 8. And then a 9 will be moderate dyskinesias. It's like the light is bright to the point that it's kind of bothering me now. So it's a troublesome dyskinesia. And then a 10 is the light is so bright. Yes, it's on, but you are blinded by the light being so shiny. So that's severe dyskinesias. What we want in our patients is to be maintained in the best on possible, 6 or 7. The most significant reduction in the symptoms of Parkinson that you could achieve without these kinesias. Now, remember that everybody's different. And I have patients that the worst problem that they have as they are wearing off is anxiety and panic attacks. In other patients is worsening of the walking or severe tremor. So what we need to do is to diminish those symptoms continuously, steadily, which you are able to achieve with infusion therapy with ONAPGO, along with your other drugs. But the beauty is that you will be able to reduce and in some cases stop some of these drugs that are being used along with your levodopa.
Awesome. Thanks, Doc. That makes a lot of sense. I appreciate it.
Thank you.
I think that's all we have. If anybody else has any questions, I'm going to make sure my information is dispersed around the group. And again, I'm Shane Smith with Supernus Pharmaceuticals here, and I cover all of Alabama. So feel free to reach out to me with any questions or concerns, and we'll just go from there. But Dr. Gill, I really appreciate your time, and
Thank you very much.
and I appreciate everybody for joining us. And
I just have one comment. I just read here that the sound was not particularly good. To the audience, what you need to do is to ask Shane and Supernus to take me to Alabama, and I'll be live from Alabama.
That's right.
Okay.
I need to get that scheduled, but thank you, Doc. We appreciate your time, and
very welcome.
have a great day.
Bye bye.